Dr. Punita Shivaprasad has kindly arranged for the next exciting speaker.
Thank you, Dr. Shivaprasad. We all need more of these absolutely valuable presentations. The stage is yours.
Namaste, everybody. I first met Dr. Menon in 2008 when I started my residency at Cooper University Hospital. She was my senior resident and a chief resident, so I was under her tutelage. I distinctly remember the day I started the internship. I was in her team. She's an excellent clinician with a great knowledge base and a fantastic bedside manners. These are the key qualities of making a great doctor, and I wanted to be just like her. It is my distinct pleasure to introduce my friend, Dr. Divya Menon, who has graciously agreed to educate us about heart disease that's plaguing South Indians. Heart disease strikes Indians early and is often deadly when it strikes. Let us empower ourselves with knowledge about our personal risk factors, the need for screening, awareness, and interventions. Dr. Divya Menon, FACC, is a board-certified non-invasive cardiologist with RWJ PE, heart specialist of Central Jersey. She will lead an interactive session to discuss cardiovascular risks and proactive measures to keep ourselves and our families heart healthy. Without further ado, let's give it up to Dr. Menon.
Good evening. Thank you, Punita, for that extremely generous and extremely gracious introduction. My name is Divya Menon. I'm a non-invasive cardiologist, and I live and I work in the area. I live in Manalapan, I work in Freehold, so we're all members of the same community. I'm here, Punita and I have had these conversations many times, and it's one of my passions to talk about prevention and screening. And I think it's such a beautiful idea to combine our celebrations with education. You know, I looked at the slogan of the Virshaiva Samaja, work is worship. And it is in that spirit of service that I think it is so beautiful to get this message out into the community. I'm looking out at the audience today and I see a sea of red. And it's so lovely to see the support in the community. Now, the sea of red to me represents that we are all curious. We are all trying to empower ourselves to learn more about heart disease, to learn more about making ourselves, our families, our communities healthier. So, before we start anything, I'm going to ask you all a question. So, simple show of hands. I want to see how many of you have had a family member who has been affected by heart disease. Put up your hands if anyone's had a family member affected by heart disease. Okay? And I see a lot of hands go up. It's unfortunately very true in our community that heart disease strikes us very early. It strikes us earlier than we start paying attention to it. Many times we don't know what the first signs are, we don't know what our risk factors are, and we don't know how to protect and how to prevent this disease. So what I'm going to talk about today, we're going to talk about many different aspects of educating ourselves. We're going to talk about effective communication, how we're going to communicate with our families. We're going to talk about information. How do you empower yourself with the information that allows you to lead a healthier life, allows you to prevent coronary artery disease? I want you to take those steps in prevention where you go out into the community, you have more educated conversations when you speak to your physicians, because you are your best advocates. So how do you speak to your physicians? How do you empower yourself with your numbers? And The next step is actually intervention. I'm a non-invasive cardiologist. My job is to keep people healthy. My job is so that you don't need an intervention. I want to prevent those heart attacks from happening. I want to prevent those strokes from happening. So to first understand what is the scope of the problem, South Asians are 4 times as likely as the average American to develop coronary artery disease. 4 times as likely. So if you're working in an office, your risk is much higher than your fellow office mates. Some part of that is genetic, some part of that is lifestyle, some part of that is diet. A lot of these factors play in. So what I'm going to do is I'm actually going to come down into the audience and we'll have a little bit of an interactive session. I'm going to give you some information and then I'm open to questions so that we can all educate ourselves a little bit more about coronary artery disease, how do we prevent it, how do we diagnose it, how do we keep ourselves healthier, okay? So I'm going to come on down. So, Representative Pramila Jaipa, one of the new South Asian faces in Congress, has actually tried to propose legislation to increase awareness of coronary artery disease in the South Asian population. So, as South Asians, we're 4 times more likely to develop coronary artery disease. So, what does that mean? It means that we have a greater risk of having our first heart attack before the age of 50. How many people here are under the age of 50? Don't raise your hands. Just, you can keep that in mind, but you're at higher risk, okay? And you know why that age group is at higher risk? That's before we've started to pay attention to ourselves, before you've started to go to the doctor, before you've started to do your screening regularly. That age where, you know, you have a little chest pain, but you think it's a little bit of reflux, but you have to take your daughter to swimming lessons and your son to tennis lessons, you put yourself on the back burner. A lot of those risk factors happen in that age group, less than 50. We also have a very high prevalence of diabetes. Type 2 diabetes and insulin resistance are an epidemic in South Asians. And why is that so? There are many factors, some of them are genetic, but some of them not so. Some of them are actually lifestyle. It's the food we eat, the way we exercise, the way we carry our adipose tissue, our fat tissue. All of that goes into increasing our cardiovascular risks. So why us? You know, we look healthy on the outside. Most of us are not overweight. You know, why should we have to worry about coronary artery disease? Many of us are vegetarian. We eat healthy diets. We are eating the way our parents ate. We are trying to do all the right things. Many of us don't smoke. We think we are leading healthy lifestyles. So why is coronary artery disease affecting us? So there is something that's special about us. And this is one field where we don't want to be special. The way we carry our fat is very different. We carry our fat around our belly, around our gut. We carry our fat in our liver. We carry our fat in our muscles. That's not a very healthy pattern of carrying adipose tissue. So that increases our metabolic risks. Also, our diet makes us slightly higher risk. Our diet tends to be very carbohydrate heavy. So even though we are vegetarian, we may eat diets that don't have a lot of vegetables. The star of our food is our carbohydrate. Our rice, our chapatis, that's the star. And we've, over the last 70, 80 years, we've moved away from the way our grandparents used to eat. We're not eating ragi mudde anymore. We are now, ragi is not making an appearance in our diet, jowar, bajra, we're not eating those ancient millets. What are we eating? We're eating refined rice, we're eating white rice. And that's become a lot of the staple of our diet. So that increases our carbohydrate load and it increases the incidence of insulin resistance. our genetics. Now, we can't change our genes. We love our families, we love our parents, but the South Asian subcontinent has given us many things, but it has also given us a genetic predisposition to coronary artery disease. So part of what I want you all to take back from this talk today is I want you to go back and talk to your families. I want you to communicate. I want you to empower yourselves with the information about your own families and what your own cardiovascular risks are. And I'll tell you what questions to ask. The other thing that happens is we have something called the thin fat syndrome. We may be thin, but our proportion of fat is very high. In fact, for the American Diabetic Association, we have a ratio we call a BMI. We have a ratio that we call the BMI, or the body mass index. Now, the BMI for the average American, beyond which they're considered overweight, is about 25. The BMI at which an Indian should be considered overweight is 23. And the reason for that is our pattern of fat distribution. That is typical to Indians, to Pacific Islanders, and the entire South Asian subcontinent, that's Indians, Pakistanis, Bangladeshis, Sri Lankans, we are all at higher risk. And this is because our pattern of carrying fat is very different. Now, our food, every celebration revolves around food. Every culture around the world, we love our food, but a lot of our celebratory foods are very high in sugars. Our mithais, our payasams, they're all very high in sugars. So we'll talk about how to enjoy things in moderation. Now, this is the question that I want you to ask all of your families. Ask your family, think about this, your parents, your brothers and your sisters, and ask your parents about their parents and their brothers and sisters. So if there is a history of early heart attacks in your family, if you have a man who's less than 55 years old and he's had a heart attack, that's too early. That makes that early coronary artery disease. If a woman has had a heart attack before the age of 65, that's early. So if this is present in your family, if your parents answer yes to these questions, you are now higher risk. And you should be proactive about taking care of your health. So ask these questions, communication. I want you all to talk to your families. We don't talk about our health enough, and we are very private about what afflicts each one of us. So we should be open, and we should be able to get this information from our families. Know your numbers. Now this is where empowerment. You have to empower yourself with knowledge. Many of you will go to the doctor, right? You'll get blood work done, you'll get labs done. But how many of you know that those labs are your property? Those labs are your information. How many of you know that you can empower yourself with that information? The American College of Cardiology makes it very easy for you to use that information to put yourself in a risk category. This is not rocket science. This is simple plugging numbers into formulas and figuring out what is your own personal risk. So know your numbers. What numbers are we looking at? Now 1/3 of all Americans and half of all Indians have something called metabolic syndrome. And metabolic syndrome is not one disease, it's a constellation, it's a collection of a few different disease states. And what are those disease states? So metabolic syndrome deals with central obesity. When you measure your waist and your waist circumference is beyond a certain number. When your blood pressure is high, when your triglycerides are high, when your HDL is low, and you have insulin resistance. Now, these numbers are all on the routine blood work that your doctor does. But it's not your doctor's property, that's your property, and that's something that you should empower yourself with. So, what is central obesity? For a man, if you measure your waist and you're 40 inches or more, you have central obesity. If a woman is 35 inches or more, you have central obesity. And it's nothing to be ashamed about. These are just numbers, and your information is power. It's not, and it's private, nobody needs to know, but you need to know for your own well-being, right? High blood pressure. High blood pressure is not just greater than 140/90. If your blood pressure is in that pre-hypertensive range, 130/85, you're at risk. You may not need medicines. You may go to your doctor may say, you're borderline, you don't need medicines yet. But that is increasing your risk, and that puts you in that criteria where you have metabolic syndrome. High cholesterol. Now for Indians, our pattern is very interesting. The American College of Cardiology guidelines are built around an LDL value. If your LDL is greater than so and so, then this is your risk. But we Indians tend to have a very specific pattern. Our HDL is low, our triglycerides are high, our LDL doesn't look that bad. So when you go to the doctor says, your numbers are borderline. You'll hear this a lot. Your numbers are borderline, you need to watch your diet. And that is where a lot of us fall. But that puts us in the metabolic syndrome criteria, in that category. HDL. Our HDL tends to be low. Your HDL is your good cholesterol. The higher, the better. How do you raise it? Things that you can do to raise it. One is genetic, which we have no control over. But you can raise it with exercise. You can raise it with certain healthy foods like nuts. So those are the other numbers that you need to know about. Your blood sugar. Now many times when your fasting blood sugar is greater than 100, many times again your doctor will say, little high, not diabetic, watch your diet. It'll always come back to that. It's a little high, but watch your diet. That puts you in the criteria of impaired glucose tolerance. And as Indians, we have a very particular pattern called insulin resistance, where our bodies are slightly insulin resistant. When that happens, the fat that otherwise, the sugars that otherwise would be directed towards producing energy are now directed towards fat production, and it's getting deposited in your liver. It's getting deposited in your gut, it's getting deposited in your muscles. So that elevated blood sugar is already a danger sign. It's something that we should be watching out for. Now, what are the other risk factors that we should all be aware of, empower ourselves with? As the years go by, our cardiac risk rises. So our risk starts early. So people in their 40s, I hope you are getting proactive about your health. I hope you have checked your blood pressure. I hope you've had at least one set of blood work. Our race we talked about already. Obesity, our incidence of diabetes is much more, and other diseases that we are much more prone to. So why does this matter? Because these metabolic syndrome increases our risk factor for coronary artery disease, heart attacks, but also strokes and diabetes. So it's not all doom and gloom. It's what we know we are high risk, fine. Now what can we do about it? That's why we are here. We're here to empower ourselves. So know your numbers, know what your age is, what your family history is, know what your blood pressure is. Get comfortable taking it. And if you're on some medicines, get a blood pressure machine, keep it at home, check it a few times a week. It's not going to hurt you. Talk to your doctor. Your doctor is part of your team. In this country, I think we have a very nice relationship with our patients where we are all on the same team. It's not like your doctor is going to tell you something and you disagree with it, and that's the end of the conversation. That can be the beginning of a conversation. If your doctor tells you need cholesterol medicines, you don't feel comfortable with it. It doesn't mean you never check your cholesterol again. It means that you're starting a conversation with your doctor. So consider your doctor as part of your treatment team and talk to them about all these options. So the American College of Cardiology has a great app. It's like a self-explanatory website. It's called a risk score calculator. And that's what the screenshot of the website looks like. It allows you to plug in your age, your gender, whether you smoke or not, whether you have diabetes, what your cholesterol numbers are, and it will give you a percentage risk. It will tell you your 10-year risk of having a heart attack or stroke is so and so. It could be 20%, it could be 1%. Usually we use these numbers. Now as doctors, we use this calculator as well. We use it to calculate your 10-year risk and decide whether you should be on cholesterol medicines, whether you should be on aspirin. A lot of our guidelines are constantly evolving. So educate yourself and talk to your doctor about this. If you smoke, please stop. You're already high risk because you're South Asian. If you smoke, then it's not a question of if you're going to have a heart attack or stroke, it's when. When you smoke, the inflammatory effect on your blood vessels is so terrible. It's like someone's taking a piece of sandpaper and rubbing it on the insides of your arteries. So a young Indian man who smokes, it is like they're a ticking time bomb. So if you know somebody in your family that smokes, get them to stop. If you don't smoke, great. That is wonderful. You've already reduced your cardiovascular risk. The other issue that we have is salt. Our diets tend to be very high in salt. Everyone's diets tend to be high in salt. It is difficult to change patterns of behavior, and it's difficult to change tastes. Many of us have grown up getting used to certain tastes, so it takes us a little bit of an effort to cut down on salt in our food. Don't add salt to anything. Get rid of salt shakers if you can. There is a very good diet called the DASH diet. And DASH stands for Dietary Approaches to Stop Hypertension. There's a lot of information on the internet. There is a website from the National Institute of Health that gives you free information. If you write to the website, they'll send you a 70-page book with recipes, meal ideas, meal planners to tell you how to reduce salt in your diet. But simple things that you can do. The battle is always fought at the grocery store. When you go to the grocery store, read the labels. When you read the labels, you will see that there is a column there that says sodium content. I would like you all to try and pay attention to that column. Whenever it says a sodium content of 20% or more of your daily requirement of salt, that is toxic for you because that raises your blood pressure. What you want to look for are foods that are 10% or less, preferably 5% or less of your daily requirement of sodium. So once you know that, you do a better job of reading labels. You do a better job of shopping and bringing those groceries home to your families. What's a healthy weight? Sorry, you have a question?
Pink salt slightly better.
Excuse me?
Is pink salt slightly better?
Not particularly. It's all sodium chloride. So all salt counts in your daily requirement of sodium. So what's a healthy weight? And I get this question all the time from my patients. They'll come and ask me, so what do you want my weight to be? And I said, I want your weight to be a weight that you are comfortable at. I want you to be able to exercise. I want you to be able to do the things that you want to do. I never give them a number. I don't like to give people numbers. I'll tell them this is your BMI right now. This is where the textbook says your BMI should be, but it's hard to set an ideal weight. You can use BMI guidelines and there are BMI calculators available everywhere. But a healthy weight for you is a weight where you are comfortable, where you can exercise, where you can run up 2 flights of stairs without getting short of breath. Exercise. If there is a fountain of youth, it is exercise. People who exercise regularly, their cells actually look younger than people of the same age who don't exercise. And it doesn't matter when you start. You could be in your 80s. In fact, there was a very nice study done by the Mayo Clinic in Jacksonville, also done by a South Asian, Dr. Srikumar Nair, who looked at aging of muscles and the effect of exercise. And he found that no matter what age people started exercising, their muscles looked like the muscles of younger people. So whenever, it doesn't matter what age you are, if you're a child, please exercise. If you're a teenager, please exercise. But even if you're 85 years old and you've never exercised before, please get up and exercise. And sorry, you have a question. Sports are like exercise. That's a great question. Yes, and you know the best habits are formed when you're a child. That's a great question. So if you grow up and you play a lot of sports, what sports do you like? That's awesome. That's a great cardiovascular exercise. So I want you to keep exercising for the rest of your life. And when people ask me what's the best form of exercise, the best form of exercise is the form that you enjoy. So if you enjoy gymnastics, find a way to keep doing gymnastics for the rest of your life. For most of us who didn't grow up doing gymnastics or didn't grow up with playing tennis, walking is a great exercise. If you can walk for 35 to 40 minutes a day, you are helping your heart, you are helping your blood pressure, you are helping your mind. If there is one thing that helps stave off dementia, it's regular exercise. So walk for 35 to 40 minutes a day and walk at a speed where you can't complete a conversation. So if you can walk and you can gossip about everything that's happened for the last few days and you walked for an hour and you feel very good about yourself, your heart didn't get the kind of exercise it needed. Your mind did, but your heart didn't. So walk frequently. I like to use activity trackers. I love activity trackers and I love technology. The Fitbits are great, the new Apple Watch is great. They all allow you to do things like monitor your heart rate, the new ones allow you to check your EKG. Give yourself a goal in terms of how many steps are you going to walk a day. I tell my patients, try and walk 10,000 steps a day. Some of them can do it, some of them can't. But you know what happens when you give them a number? Then they start looking at how many steps am I walking right now? And they check and you're walking 2,000 steps. May not seem like a lot, but the next time they come in, they're walking 3,000 steps, which is better than what they were doing 6 months ago. And then slowly they build up their exercise capacity. So be accountable to yourselves and be accountable to your families. Now, treating high cholesterol levels. So my first recommendation is always diet, weight loss, increased physical activity. But there are times when all these measures are not enough and when medications are appropriate. And I have this conversation with my patients all the time. If you need a statin, then a statin medication may be the best thing for you. We don't have a lot of medicines that have been shown to help people live longer. But for the right person, a statin can be that medicine. So if you and your doctor have a conversation and your doctor says, listen, I really feel strongly about this, you should take a statin medicine, consider it. You know, it's not the worst thing in the world, it's not a failure, it's not that you failed with diet and exercise. Sometimes you just need that additional help. So be part of the team and allow for shared decision making. You and your physician should be able to make that decision together. So questions. Now before we go to questions, I'm just going to talk about one other thing that allows us for screening, and I like this a lot in my South Asian patients. It's a newer test, it's called a CT coronary calcium score. And the newly updated American College of Cardiology guidelines have started to support the use of calcium score for screening in high-risk populations. And what that is it's a CAT scan of the chest, it's a low-dose CAT scan that takes a snapshot of your heart, sees how much calcium you have and compares you with the average person your age. It's not right for everybody, but for the right people, it allows for an important part of that shared decision-making process where your doctor can empower you with that information. They can tell you, listen, you have more calcium than 95% of men your age. You really should take a statin. It gives you a little bit more information, a little bit more power. So there are lots of newer interventions, newer diagnostic tests that are out there, but it's important for all of us to empower ourselves. Okay? So that was my little piece. I'm open for any questions if anybody has any.
Is it important to get the A1Cs done to understand whether you're in the type 2 diabetes and stuff?
So I don't use the A1C as a pure screening test for everybody. I like the fasting sugar a little more, but if your fasting sugar has been slightly on the higher side, absolutely. The A1C is a very powerful tool to try and figure out what your blood sugar control over the last 3 months has been. So it's a very useful tool, and for the right patient, it is a very valuable part of our decision algorithm.
Where and when is your next screening?
We're screening all the time. So our offices are right next to Central State Hospital, and we do a lot of public screenings there. If you look at the Health Awareness Center at Central State, they have free lipid screenings, we have free vascular disease screenings. So you're free to look up the website and, excuse me? It's centralstate.org, I think. I haven't even looked. But that, if you just Google it, Central State Health Awareness Center and screening.
Question. There's a lot of controversy in the baby aspirin.
Mm-hmm.
Recently, they said that it's no longer needed for healthy people.
Mm-hmm.
What's your comment on that?
So that's actually been a lot of very interesting data that came out over the last 2 years about the use of baby aspirin. If you asked me the same question 3 years ago, I would have said, yes, men above the age of 55 who have more than one risk factor, it's good for primary prevention. But the beautiful thing about medicine, and especially about cardiology, is that our knowledge keeps changing. And by the most recent Australian studies have shown that there is no role for the baby aspirin, the 81 milligrams of aspirin, for primary prevention. That is to prevent an event from occurring. But there is still a role in secondary prevention, whereas if somebody already has a stent, if somebody already has had a heart attack, then there is a role in the baby aspirin. So we are taking a lot of our healthy patients off of it, but if you have a reason to be on it, not just yet. Sorry, you had a question? So, sorry.
Are there any gene therapy interventions available for arthritis?
So we don't have gene therapy as in targeted gene therapy for modifying our own genetic risks. What we do have are newer agents that are targeted monoclonal antibodies that work towards people who are resistant to other medications, to statins and others. But into the field of cardiovascular medicine, we don't have targeted gene therapy to modify your personal risk factors. So if you have a strong family history, do I have a gene therapy that would reverse that? Not yet.
If you have low blood pressure or if the heart is not pumping appropriately, the fluid builds up in your lung. Why?
So there are many different aspects to that question. So just to repeat your question, the question was, if you have low blood pressure and the heart is not pumping well, why does fluid build up around the lungs? So there are many different aspects to that. So first, the low blood pressure by itself does not mean that your heart is not pumping well. But if the low blood pressure is associated with something called a cardiomyopathy or congestive heart failure, that can cause the heart to pump blood less effectively. And when the heart is not pumping blood effectively, that's when congestive heart failure symptoms start to show themselves. One of the symptoms is fluid buildup in the lungs. So the low blood pressure may be incidental, but I think the question that you're asking me is, why does fluid build up in the lungs when the heart is not pumping well? Because the heart and lungs are interconnected. When the heart can't pump the fluid out, there is a back pressure of fluid that builds up in the lungs that causes fluid to build up.
Thank you, doctor. We'll take 2 more questions. Next is Dr. Hill.
Hi, I'm a radiologist myself. First of all, thank you for the excellent presentation. I have 2 questions for you. One is lipoprotein A. Especially that's the most important test we have to have. That was not included in the presentation. I want to emphasize lipoprotein A. When you go for the routine blood test, your doctor never includes that. If you're Indian, you must have that test. Correct? What are your thoughts?
I completely agree with that. It's not part of routine screening, and the reason why I didn't bring it up here is because it's not yet part of the American College of Cardiology guidelines. However, I personally love the test because it is another surrogate marker that allows me to risk stratify my South Asian patients a little better. We tend to have higher lipoprotein A levels. That is a kind of our, as you very well know, that's kind of our genetic heritage. So that higher lipoprotein A level tends to make us higher risk. Now, our conventional statins don't work so well to bring down lipoprotein A levels, but it's a very useful surrogate marker. So I absolutely agree with you, but I didn't bring it up here because it's a little hard for me to put it in a public screening lecture because it wouldn't be entirely appropriate for patients to go back and ask their physician, listen, I need a lipoprotein A level with this, when it's not part of the guidelines.
All the insurance companies are paying for it.
Right.
Second question for statins.
Yes.
Let's say I'm a 40-year-old man or woman. I don't have diabetes. Mentally I'm fine. The problem with statins is dementia, and I might develop diabetes. So what are your thoughts?
So it's the risk-benefit ratio, and we like the 10-year ACC-AHA risk calculator to try and give people an estimate of what their cardiovascular risks are. So if their risk is greater than 7.5%, then we have a conversation about statin use, and we talk about what the outcomes of being on a statin could be. Now, for some people, there is an association between statin use and impaired glucose tolerance. Now, it hasn't been documented as a causation, but we see it all the time, where we start to see those fasting sugar levels go up a little bit after statin use. But for people who actually need the statin, I find it a little hard to deny them the benefit of the statin for the theoretical possibility that their the blood glucose might go up. And again, the statin incidence and the use of statins and the incidence of dementia, it's the same issue that we have, where if there's someone with coronary artery disease who has a stent, where the statin would actually demonstrably increase their lifespan, then it's very hard for me to deny them that for the theoretical risk of that small possibility of causation of dementia. So I don't use statins as frequently for people who don't have an absolute indication, and that's true for anybody who takes statins. But you're absolutely right to bring up those concerns, and I talk about this with my patients all the time. Because listen, when we start you on a new medication, you have to talk about every possible side effect. And if the benefits exceed the risks, then absolutely we go ahead with the medication.
Thank you.
Thank you very much.
Sorry, thank you, doctor. We'll be closing the questions. Thank you.
Thank you, Divya. It was excellent. So we would like to give you a small token of our thanks from all the members of the DSC.